A mother awake at 2 in the morning, listening for a car in the driveway, or a patient lying in bed after a terrifying diagnosis. When fear hits in the middle of the night, the easiest thing to do is pick up a smartphone and ask a chatbot for help. In 2023, radiation oncologist Dr. Danielle Bitterman at the Dana-Farber Cancer Institute tested how well the world's most popular AI handled that scenario. Her team ran the bot against strict national oncology guidelines for breast, prostate, and lung cancer. This chart breaks down the AI's responses. 34% of the time, it provided advice contradicting established guidelines. But watch this red slice. 98% of those wrong answers were packaged alongside medically sound advice, making them nearly impossible to spot. An algorithm that speaks fluently sounds authoritative. When a system camouflages its mistakes behind perfect grammar and confidence, it poses a direct risk to anyone seeking immediate medical guidance. Tech industries routinely operate on a strategy of shipping a product first and fixing it later. In healthcare, that model has to be replaced by a strict protocol, an active human supervisor, and a public scorecard. That requirement for human supervision is exactly why Clinician Assist sponsors this video. They build software specifically designed to keep a licensed medical professional in charge of AI tools, ensuring the algorithm is always managed by an expert. Right now, hidden inside federal grant databases and clinical trial registries, a quiet movement of researchers is building these tools safely. Let's look at 3 scientists defining this new standard. Their work shows how we transition from wild, unpredictable algorithms to reliable, clinically tested medical tools. First is the training pillar. Dr. Sarah Dauber is the Vice President of Research at the Partnership to End Addiction, an organization that runs a national helpline for families of people struggling with substance use. Notice how this data pipeline is structured. Instead of letting her AI, a project called Halo, scrape random internet forums, Dr. Dauber is training it exclusively on 40,000 actual conversations that her own human counselors have already had with families. Before this system can expand, it hits a hard stop. Halo is required to clear a 3-month pilot test with just 60 families. Only if it meets predefined safety and feasibility benchmarks will that gate unlock, allowing it to move to a larger 800-person trial. The objective here is to embed the tool directly inside the existing helpline. It learns from a decade of human empathy to support the peer coaches, extending their reach to families who are highly distressed and traditionally underserved. Rather than launching a consumer app on faith, a clinical tool proves its safety at a micro level to earn the right to scale. Next is the testing pillar. At the Fred Hutchinson Cancer Center in Seattle, psychologist Dr. Jonathan Bricker spent 4 years designing a smoking cessation chatbot called QuitBot, focusing entirely on proving its efficacy against a strong competitor. This chart compares QuitBot against the National Cancer Institute's own text messaging program. Among participants who finished the pilot, QuitBot achieved a 63% abstinence rate at 3 months, compared to 38.5% for the government standard. Dr. Bricker didn't cash out after the pilot. He completed a massive 1,647-person trial, following patients for a full 12 months to establish a rigorous evidence bar for the entire cessation category. Now his team is adapting that tested framework into a project called Native. This version is designed specifically for American Indian and Alaska Native adults, populations that face the highest rates of commercial cigarette smoking and half the odds of quitting compared to other groups. Crucially, Native is being built from the ground up through dedicated community partnerships, ensuring the tool actually fits the culture and infrastructure of the people it serves, rather than just appearing as a download link in an app store. True medical progress requires proving clinical supremacy over existing tools, and deliberately adapting those successes for the populations with the worst access to care. This brings us back to Dr. Danielle Bitterman in Boston for the final requirement, the bounding pillar. Her current work at Brigham and Women's Hospital focuses on strictly limiting what an AI is permitted to say. After her first study, she measured the risks of using AI to draft doctor replies to patient messages. She found that while many drafts looked acceptable, 7.1% of unedited responses posed a direct risk to the patient, and 0.6% carried a risk of death. To solve this, she secured federal funding from the National Cancer Institute to build AI Chase, a chatbot designed to educate cancer patients about their symptoms with rigid clinical bounding. Look at the architecture of this system. When a patient asks a question, the prompt intentionally bypasses the AI's generative memory. Instead, it is hard-coded to link directly to a locked database of official clinical practice guidelines, forcing every answer to be grounded entirely in established medical documents. By cutting off the algorithm's ability to guess, the system is structurally blocked from hallucinating. To operate safely in healthcare, a model needs to be trained on actual human expertise, tested relentlessly against government standards, and tightly bounded by clinical guidelines. If you look at what Dr. Dauber, Dr. Bricker, and Dr. Bitterman are doing, none of them asked for permission to let a machine run loose. They agreed, in advance and in public, to be measured against strict scorecards. That is the exact approach championed by Clinician Assist, whose software is built to ensure a licensed professional always remains in the loop, supervising the technology at every step. A reliable medical tool isn't defined by who ships it first. It is defined entirely by who takes the time to prove it is safe.